So we're going to start with the renal and renal system. So the website, hopefully everyone had access to. I want to review the outline. Please sign in. Sign in for today. It has several questions asking you, your thoughts, also sort of what you learn and are uncomfortable learning or you're not comfortable with still. It gives me an idea of your strengths and weaknesses after the lecture. Read this book if you haven't had a chance to do so. It's an outstanding book and it'll help you with the USMLE exams and eventually your board exams. But we will be using the principles from those books. So I have multiple choice questions, pre and post quizzes, and then we'll be doing interleaving and repetition. So here you have access to the contents that we'll be covering today. The PowerPoint slides are also on this, and then this is the goals and objectives. So the goals and objectives are taken directly off of the USMLE Content List. The USMLE Content List is what the board has said you should know for the step 1. So these are from there, and the lectures are based on the content list. Here's the list of the content list that comes directly from USMLE related to the topic of renal and the collecting system. What else? And this is the first aid. So the first aid has content that I took directly from and added to the lecture. So I'll be referencing them as we review. Any questions? Okay, I'll take that as a no. So class email, I think we went over. What else? We are scheduled to have 3 other lecture series right now. Cardiovascular, respiratory, and GI. And the lectures will be posted after the recordings have been uploaded. And it'll be posted here. The Men's Health series is another set of lectures that I'll be giving you your second year. Okay, so let's go ahead and get started. It's 11:07. When does the class end? What time? Is it noon or is it earlier? Anyone know? At 12. Okay, so we have 50 minutes. Okay, great. So let's go get started. So we reviewed the website. We did the pre and post quiz, sign in, and how to participate. So you can use a chat box. I think there's like a way for you to raise your hand electronically or just ask the question. So we'll start off with a lecture quiz. We'll review normal lectures, normal structures, infection, tumors, trauma and mechanical disorders, and congenital disorders. Again, these are all taken directly from the USMLE content list. So we have 5 quiz questions that are different from the pre-quizzes that you guys took. What exam is this? Urogram, a nephrogram, cystogram, or avoiding cystourethragram? Any guesses? You can text in your responses if you like. And I'm not going to proceed until I get some answers. Perfect. Okay, nephrogram, urogram. Good. What is the arrow pointing to?
I'm all right. How are you?
Muscle, abscess, bone, spleen. Which was the answer? We're going to review these answers later. So what is the arrow pointing to? The spleen, the kidney? Okay. So is it, the kidney is not one of the answer choices. Abscess. Okay. Awesome. Great. Perfect. Patient has caseous necrosis and on pathology and has the following imaging finding. What is the diagnosis? Renal cell carcinoma, TB, laceration, azotemia. TB, okay, so people are guessing TB, good. A patient has retinal hemangioblastomas, and these are the findings seen on imaging. What is the underlying syndrome? VHL, Burghoff-Dubé, tuberous sclerosis, hereditary papillary leiomyomatosis, VHL. Okay, we have maybe some people are choosing D, mostly A. Okay. What part of the kidney is the arrow pointing to? The renal pelvis, the renal calyx, infundibulum, fornix. Okay, we have people voting for calyces, fornices, mostly calyxes. Okay, great. What's the difference between the calyx and the fornix? What's the difference between the calyx and the fornix? It looks like we're split between those two responses. Fornix is the opening, like here. Okay, we'll review that. Any other guesses? Oh, I think maybe JJ was referring to this. Yeah. Great. So now we're going to go ahead and get started with anatomy. What is the structure here? The spleen. Good. And what about this? The liver. Good. And these are the bilateral kidneys. And what's the structure here down the midline? Esophagus. Well, it has contrast in it because it's bright. Aorta. Good. Okay. And then what is this thing here? What bowel is this? That goes on the right side and the left side along the pericolic gutters. Okay. More specific. Good. Descending colon. Good. So there are different parts to the kidney. So this is what part of the kidney? Renal pelvis. Good. And then the renal pelvis then branches into, like I think 6 or 9 renal calyces. And what is the channel leading into the calyces? What is that channel called? Infundibulum. Good. And then the renal calyces, then lead into the renal fornices here. So if you have severe hydro, those fornices can rupture, and then you can get retroperitoneal fluid collections. Good. So we're going to be reviewing primarily the renal collecting system, which includes the upper tract, the bladder, the urethra. So sitting on top of the kidneys are the adrenal glands, and that's part of the retroperitoneum, which is separate from the peritoneum, which has bowel, colon, parts of the pancreas, stomach. This is a CT. A CT, we use radiation. In contrast, this is what kind of imaging modality? Good, MRI. So in MRI, do we use radiation or no radiation? Good, no radiation, right? It's looking at proton spins. So it's a magnetic field, and so it's great because there's no radiation, but the disadvantage is that it takes much longer to acquire than a CT scan. These are parts of the kidney. So a compound calyx, that's just mean there's more than one calyx. You have a simple calyx, which is a single. The renal pelvis, you have the infundibulum that leads into the renal calyces, and then the fornices, which are at the tips. You can sometimes get fornicial ruptures. Good. So a CT urogram is a study that we use to evaluate the collecting system. The collecting system is made up of starting from the calyces down the pelvis, ureter, bladder, urethra. So the urogram, what we do is we inject contrast, and the contrast follows blood. So we give it intravenously, and then it goes into the circulatory system. Just as water and fluids will then be excreted via the kidney, it'll go through the filtration process, and then will eventually make it out into the collecting system, bladder, and then patients will pee it out. So this is useful because we can now see the collecting system light up. So the way we acquire it is we give the IV contrast and then wait about 10 minutes because that's how long it takes for it to be processed by the kidneys and then eventually excreted. And then we acquire the images. So this is a CT urogram. This is an MRI. So you can do the same thing with CT or MRI. And what you get depends on what the clinical indications is. So most patients will just get a CT urogram. Some patients, for example, if they're young, if they have allergy to iodine, which is contrast, they can get IV gadolinium because there's no reaction. But in general, we prefer MR. But in terms of, because you get better soft tissue resolution and there's no radiation, so that's a bonus. But if you ever wanted to know what study to order, you can always look up ACR, American College of Radiology, appropriateness criteria. So here's a coronal reformat, and we see that we know this is an excretory, right? Because look, the aorta is not light up. What is lit up is the collecting system, renal pelvis, the bladder. So we know this is a delayed phase. There are we can acquire images in different phases. Earlier, we saw the aorta light up. That's called the arterial phase because the contrast is in the artery. Eventually, it'll go into the capillaries and then come out the veins. And then if the vein is lit up, which happens like at about 45 seconds, then it's a different phase called the venous phase. And then this one is called the excretory phase, which is 8 minutes after contrast injection because now it's in the collecting system. So we're going to be looking at a lot of excretory images today because we're evaluating the collecting system. This is called a retrograde urethragram, and it evaluates the lower urinary tract, so the urethra. So what structure is this? Bladder, good. And so this is the bladder neck, and then this is the man, because we can see the shadow of the penis here. And this is the prostate here, which we don't see well because the urethra is compressed by the prostate, which is normal. And then you have the urethral sphincter here. That's why you don't see reflex. And then here is it's a little catheter with the balloon inflated, and then we inject contrast to then look at the urethra. These are the different parts of the urethra. You have the anterior urethra, which is anterior to the urogenital diaphragm, and then you have the posterior urethra, which is upstream of the urogenital diaphragm. So what imaging modality is this? Ultrasound, good. And what structure are we looking at? It's the kidney, good. So ultrasound is really great for looking at the kidney because the kidneys are very close to the posterior soft tissue, your abdominal wall. So you have good access to it. And so ultrasound is really great for that. Here we have the renal pelvis, and then with ultrasound we use the word echogenicity because that's what we're evaluating. Ultrasound was developed by the Navy, where they emitted ultrasound as like sound waves and then listened for the reverberation. And so those things, sonar, exactly. And so that creates an image. So ultrasound is really great in general for renal collecting system. Anywhere you have a nice window. It was designed for water, so you need some kind of interface. If there's air, then it makes ultrasound useless, although it can be advantageous at times. So what structure is this that we're looking at? Yes, air and sound. This is the bladder, good. So this is the function of the renal system. When we do an ultrasound, we look at the kidneys, we look at the renal pelvis, look for hydronephrosis. You can see kidney stones, and we'll see examples of it. And then you go down south, look at the bladder. You can look at the get the ureteral jet to get functional information. So with ultrasound, you can get grayscale, which is what we're looking at right now, or you can get color Doppler images, which gives you velocity and flow. And we'll see some images later. Okay, so now we're going to go down the list of the USMLE content list. Okay, everything here is taken directly from that. So it's in the order that was highlighted in the content list that we reviewed at the beginning of the lecture. So what kind of imaging study is this? CT, good. And is it with or without contrast? With contrast, good. And why do you say it's with contrast, Nilik? The kidneys look like they're lighting up. Yeah, exactly. So, you know, the kidneys are bright here, so we know that it has contrast. And remember earlier we saw the aorta, it was bright, but now the aorta is not very bright, the kidney is bright. So we know that this is not the arterial phase, this is a venous phase because it's already in the renal parenchyma. And then, you know, then it'll get excreted into the renal pelvis and then down the ureter into the bladder, in which case it now becomes an excretory phase, which is 8 minutes. This is the nephrographic phase, which is about 3-4 minutes. So here we see the striation patterns here. It's sort of like starbursty here. Normal kidneys is homogeneously enhancing. It should all look nice and uniformly bright, but here we see these bands of areas where there's no contrast coming in. And this is, we call this a striated pattern, which happens in the setting of pyelonephritis. So pyelonephritis is infection of the renal parenchyma, and it's most commonly due to E. coli. Patients with diabetes are at an increased risk, although non-diabetics can also develop it as a complication of bladder infection, cystitis. Complications include sepsis, so that's the feared complication. The bacteria can translocate into the vessel and then patients can get into septic shock. Renal papillary necrosis, where the papilla starts to die off and slough off, and you can get abscesses. And in certain cases, it can go on to become an indolent infection and have chronic pyelo. And here is an example of chronic pyelonephritis. So which side is abnormal, the right or the left side? The right side, good. So what is abnormal about the right side? Why do you say it's abnormal? So the left side, it should be, it's normal kidney. It's homogeneously enhancing. The renal parenchyma, you know, it looks normal. The collecting system is not dilated. The right side, it looks cystic. Someone said this, Joseph. Right? There's calyceal dilatation. The cortex is very thin. Here, the cortex is nice and thick and normal looking. Here, the cortex is very thin. So you know there's chronic kidney disease because this is what happens when you have chronic hydronephrosis. You start to get, the cortex start to get thinned out, so you lose normal parenchyma. And what else do you see? What are these high density material in the renal pelvis, which has the same density as bone? Calcifications, yeah. So calcification in the renal system is called renal stones, and that's what this is here. So the patient has renal stones that's causing chronic obstruction. That's why we see calyceal dilatation and with secondary renal cortex thinning. So this is what happens with chronic pyelonephritis. The patient never got their renal stones treated, so then it went on to this indolent infection, and then the kidney then became, you know, sort of compromised. So this form of chronic pyelonephritis due to renal stone burden is called xanthogranulomatous pyelonephritis, and it is due to chronic obstruction, and then what we get is this granulomatous process that forms, and patients with XGP do not respond to IV antibiotics and they need nephrectomy. Proteus, I think you're right. Proteus, let's find out. Pro XGP. Proteus. So is yeah, good job, JJ. XGP is most commonly associated with Proteus. infection, there are complications associated with untreated infection. So one complication is what we see here. So where is this the normal location of the kidney? If not, why is it causing this appearance? Any thoughts? So here's the normal right kidney, which is in the retroperitoneum. Yeah, exactly. So Nikhil and JJ. So there is this hypoattenuating fluid collection. It has the thick rim, and it's causing mass effect and displacing the left kidney anteriorly. And you said, Michelle, you said failure to treat kidney stones can lead to chronic pyelo. What is the treatment? I thought kidney stones usually passed. That's a great question. So kidney stones, the way you treat kidney stones depends on the size of the kidney stones. The kidney stones less than 1 centimeter will pass typically on their own. They'll give a conservative management, so pain control, lots of fluids, and sometimes they'll give muscle relaxers, alpha blockers, to help the small stones pass. Stones that are bigger than 1 centimeter, this stone is probably 5 centimeters, 2.5, 3 centimeters. So stones in general that are greater than 1 centimeter require intervention. So depending on the size, they can either do a retrograde ureteroscopy, so they put a camera into the bladder and then put a little small camera up the ureter. If it's 1 to 1.5 centimeter. If it's larger, then they can do a percutaneous nephrolithotomy, where they make a hole here, basically a tract, direct access into the kidney, and then they can go in and then extract the stone that way. So this patient, so here is what a PCNL looks like, percutaneous nephrolithotomy, which is what this patient would have needed had he sought treatment. So they put the nephroscope directly into the kidney through the soft tissues, and then they basically use a small version of a jackhammer to break down the stone and then extract it. So in this case, it would not have passed on its own. Maybe the patient didn't see, health, provider, or maybe I don't know why, but the patient didn't get proper treatment. And so then it went on to develop a chronic pyelo and XGB. Okay, so we have an abscess. Here's an example of another abscess, which this is covering, but it's very similar. We have stones, so we call these Staghorn calculi, when the stones are so excessive that it'll go into the calyces, and these typically require PCNL, percutaneous nephrolithotomy, because the stone burden is too much. Here's another complication of untreated upper tract infection, or in this case, an obstruction, is hydronephrosis. Here is not simple hydronephrosis, and the reason we know that is because the urothelium is lit up, so there's inflammation, there's hyperemia, and what else do you see? Do we know what the hydronephrosis is from in this case? Any budding radiologists in the audience? Stone, yeah. So there's an obstructing renal stone in the left mid-ureter that's causing hydro, and it's a complicated hydro, so it's probably pyelonephrosis, and we really need, patient may have fever, elevated white count, maybe septic, depending on the severity and the chronicity. And we see that the perinephric space, there's stranding, so there's inflammatory changes around the perinephric region as a complication, and this can lead to a forniceal rupture abscess. Okay, so then here's just an axial version of that. You have hydronephrosis, pyelonephrosis, when instead of simple fluid, it becomes infected pus. So this is why stones have to be treated, is because patients can rapidly develop urosepsis, and it's one of the leading indication, not indication, but emergent cause of death in the third world countries where they don't have access to proper health care is obstructing renal stone because patients develop urosepsis and die of septic shock. So in these cases, the collecting system has to be decompressed emergently. So they can either put a nephrostomy tube to decompress it, or they can put a stent in the ureter so that the pus can drain out. The stone can be managed at a later time. The more important thing is to decompress the renal collecting system to prevent urosepsis. And, you know, when it's this severe, you don't want to muck around because you'll just increase the risk of translocating the organisms into the bloodstream. So that's why you take care of these stones at a later time when everything has cooled down and, you know, we don't have this risk. Here is a video of how we place a nephrostomy tube. So patients, for example, in the that last case that had an obstructing renal stone, this is how you can decompress the renal collecting system. You place an access needle through CT or typically ultrasound guidance. You put a guide wire in, and then you do serial dilatation. And then after that, you can then place a catheter in. The pigtail, they call this a pigtail because when you pull the string, what it does is it coils that tip. That string is attached to the tip, so it coils it so it looks like a little pigtail. And then you loop it around. And so this is important because when you guys start on your third year rotation and you see a pigtail, if you want to remove a pigtail, you have to release that coil. So the way you release it is to cut this, is to, make the string lax or either cut the catheter because you need to release that coil. You can't take it out if you don't release it because it'll be stuck. Yes? Okay. So here is an example of a patient that had exactly that done. So the patient is on the CT scanner and I don't know if you can see it, but there's an abscess in the collecting cyst in the kidney right there. There's an abscess. And then, so we put in a pigtail catheter to decompress it. And then you can, once the patient heals, then you can remove the pigtail catheter. Okay, any questions? Okay, so other infections that you should know of is renal TB. So renal TB, I wonder how I can get rid of this. It's blocking, sorry, yeah, the bottom part is blocking the bottom part of the slide. But renal TB, it's an indolent infection and it can progress on, typically starts in the respiratory system. In patients who sort of go untreated, it can spread into other systems, including the renal and the collecting system. So here are examples of late stage untreated TB. So you get calyceal dilatation, you get ureteral thickening from the inflammation, the TB, and then you can get strictures of the infundibulum narrowing that can lead to calyceal dilatation because the channel is just fibrotic and chronically inflamed. And of course, path, you get this caseous necrosis appearance. So I'm going to have these yellow markers where I take materials from first aid, that things that you should know, and it's going to be repeated so that, hopefully the multiple repetition will help put this information into your long-term memory bank. But the agar you need to use is this Lowinston-Jensen. It's an aerobic bacteria. There's two forms, primary and secondary TB. So primary is the initial exposure. They get a Gone complex, which is that's how the body reacts. It looks like an abscess. Typically in the lower lung lobes, you get lymphadenopathy. Secondary or reactivation occurs in the apical segments of the lungs where there's more oxygen, and you treat it with the RIPE regimen. Okay, moving on to neoplasms. So you should know about Wilms tumor, also known as nephroblastoma. It's the most common childhood cancer, 2 to 4-year-old. They typically present with flank mass, hematuria, and palpable mass on exam. It's due to loss of tumor suppressor gene, WT1 and 2, and can be part of 2 syndromes, the Wagner syndrome, Wilms aniridia, with associated GU malformation, or the Beckwith-Wiedemann syndrome, where you have macroglossia, organomegaly, and hemihypertrophy, where you have asymmetric enlargement of certain parts of the body. Moving on to sort of adult cancers, clear cell carcinomas are the most common renal cell carcinomas in adults, and also the most common subtype clear cell of the RCCs. Just FYI, I don't have my chat box open, so if you guys are asking questions, I'll look at it later because I have this on full screen. Risk factors, so smoking and obesity will increase risk. It's on chromosome 3. Because of the advent of CT, most of the findings now are incidentally found, and incidental lesions are called incidentalomas because we do CT so much in the ERs and whatnot that most are found accidentally. So we don't actually see them present this typical way anymore, which is hematuria, palpable mass, and flank mass. It can invade the IVC. So here is a CT, and what do you see on the CT? Should you, okay, I'm going to answer this question really quick. Let me see if I can. I need to, So the question from Milo was, should you remove the stone before taking the catheter for the drainage of hydronephrosis? Oh, yes. So correct. So when do you take out the nephrostomy tube? So we take out the nephrostomy tube after we know that the ureter is patent. So correct. So we typically won't take out the nephrostomy tube. They'll remove the catheter. They'll typically put a double J stent into the ureter. And once they know that the patient is now able to pass urine through the ureter, then they'll cap the nephrostomy tube. So the nephrostomy tube trial, they'll cap, oh, sorry, this is probably asked a while back, it looks like. They'll cap the nephrostomy tube, let them do a voiding trial so that they know that the patient is able to, the lower tract is patent. And then once they know that, then they'll take out the nephrostomy tube. Okay, great. So next question. What was my question? Okay, I need to have this chat box open so that we don't have to keep going back and forth. Okay, so this is, oh yeah, so what, this is a CT scan and we see an upper pole mass. And here is, what kind of imaging study is this? This is an MRI, good. So it's an MRI and it has contrast. And we know this because part of the liver is lit up, the kidney is lit up. And which side is abnormal, the right side or the left side? How do you know it's MRI? We know it's MRI because of the sort of slight differences in the imaging. So here, bone is bright. That's what CT scan, the bone is typically bright.
Hey, come on. Stop it.
Okay. So on the MRI, the bone is typically dark. So there's slight differences in the imaging appearance of the organs and the structures. So that's why we know it's MRI. What else? Yes, so MRI does have lower resolution than CT. You see how here you can see sort of details really well. Here it's like not as high res.
Come on.
Okay. I think someone's talking, so I'm not sure how to. Okay. All right. Mute button is on the bottom left. Okay. So, all right. I'm going to keep going. RCC. So here, well, okay, left. This is the left kidney's abnormal, and look at the renal vein. So here is the renal vein. Let me see. I can pause this thing. Oh, it's I made it into what do you call it, GIF, so I can't pause it. But the renal vein is going into the IVC. And the left, you see, is also going into the IVC. But the left is expanded and it's bright, so it's enhancing. So that means there's this mass here in the left upper pole, and kidney cancer classically goes into the renal vein and then crawls up the IVC and it can go into the heart. Okay, so this is a renal vein invasion of RCC. Associated with VHL, von Hippel-Lindau syndrome, patients with VHL have problems with the HIF-1 alpha. So there's a constant state of hypoxia, which leads to angiogenesis. Patients with RCC can be treated with nephrectomy or can have an ablation. RCC is, and I'll show you what an ablation looks like. So in patients who have a smaller tumor, who don't have vascular invasion, we can use CT guided. We put a needle in here. The tip of the needle burns. You can either freeze it or burn it. We typically use burning because freezing it increases the risk of the ice ball getting cracked and lead to like bleeding. So you can burn it, and you burn and encompass the whole tumor. This is, patients come in, get the procedure done, and then go home. It's like a dental procedure, for example. So that's how we can treat renal masses, lung cancers, liver cancers, a lot of different cancers if they're localized. Or you can do a partial nephrectomy, but there's advantages and disadvantages. Obviously, with partial nephrectomies, there's a lot more complication rates. It's a more complex procedure. Patients are hospitalized for a few days. There's a lot of problems. So sometimes less is more. This is what an ablation looks like. Okay. The second most common type of renal neoplasm is called oncocytoma. And oncocytoma is very hard to distinguish from clear cell renal cell carcinoma. The reason you need to distinguish it is because it's benign. So these don't have to be treated. And the best way to differentiate them is with biopsy. In certain kinds of oncocytomas, you can tell by imaging, but most cases will need biopsy. Okay. So let's review hereditary syndromes that USMLE Content List says that you should know. The most important one is VHL, which is associated with clear cell RCC. Chromosome 3, they also get pancreatic tumors, they get hemangioblastomas of the retina as well as cerebellar. And we said HIF-1 alpha is involved. Berghog-Dubé is another type. They get oncocytomas, skin lesions, and lung cysts. And tuberous sclerosis, so they get angiomyolipomas, lymphangiomas, facial adenomas, and tubers. Know the VHL. TS is second most important, and Berghog-Dubé is, if you're going to forget something, you can forget that, because it's not common. So just so that we can give you more examples of VHL, so here we have hemangioblastomas that we see, that the ophthalmologist sees, and this is the angiogram equivalent of that. Here we see an MRI, and there's a mass here. They get multifocal clear cell renal cell carcinomas, okay, multifocal, and sometimes bilateral. These are associated with pancreatic tumors, which you can see here. And they get cerebellar hemangioblastomas, which we see here. This is a contrast-enhanced MRI. This is a T2. We know it's a T2 because CSF is bright. And T2 looks at water. So you look for bright, white CSF. So Michelle has a question. What was the difference between those two that you said are difficult to distinguish? Benign versus malignant? Yes. So the difference is, yes, the main difference is that oncocytomas are benign, and clear cell renal carcinomas, clear cell RCC are not. So because their clear cell RCC is malignant, they usually need to be resected or ablated or treated somehow. And they they can metastasize. Oncocytomas, on the other hand, it's like fibroids, they'll just grow, but no, they won't metastasize. So you don't need to ablate them or just resect them. Are there other conditions in Burgh-Hogg-Dubé benign as well? Can you expand on your question, Milo? I don't really know. So your question is, are there other conditions associated with Burgh-Hogg-Dubé? Is that your question? The fibromas and long. Oh, are they benign? Yes. So Burgh-Hogg-Dubé, yeah, skin fibromas and the lung cysts. Those are usually lymphangioma, we call it. They're benign. It's when you see a collection of these findings, then you think, oh, maybe they have a genetic disorder, but they don't actually need to be treated. You just have to be careful because these lung cysts can rupture and cause pneumothorax. Oncocytomas, they happen, we see them with BHD, but you see them, you don't have to do anything because they're oncocytomas. Okay. So it's similar with TS. These are all benign, angiomyolipomas, adenomas, but the problem is not the malignancy, because they're benign, is the complications that they cause. So angiomyolipomas can get so big that they can rupture because it has vessels, right? Angio, vessels, myo, muscle, and fat. So if they get so big, the vessels can rupture and they can get retroperitoneal hemorrhage and, basically exsanguinate. And tumors. So tumors we see in the brain, and you don't want anything growing in the brain if possible, even if it's benign, because tumors can lead to chronic seizures, and so they can have intractable epilepsy. So VHL, but VHL is associated with malignancy, and the malignancy is clear cell. And retinoblastomas here, these have to be treated because you can imagine they can bleed. Remember, it's associated with HIF1 alpha. So VHL, these tumors, lesions are very vascular. So that the sequelae of the vascularity is what causes problems. And hemangioblastomas, it can cause mass effect, if it's in the wrong place, and then that can cause complications. Pancreatic tumors, and pheochromocytomas, okay? Okay. So I'm going to go a little faster because I've been kind of going slow and we have to get through the cases. So Burgh-Hogg-Dubé, so we get lung cysts. Again, these are benign. The problem is that they can cause pneumothorax. So that's why it's important to keep those in mind. Here, tuberculosis, again, it's benign, but these tubers, they become foci for seizure activity, which can become very problematic. And they get cysts as well, which can cause pneumothorax. And then angiomyolipomas can bleed. So it's a complication of, despite benign sequelae. And here is angiomyolipoma. This is an angiogram. And you can see this, large vessel. And here they can embolize it so that they can prevent risk of bleeding. Now we're going to move on to the upper tracts. So here we have a soft tissue in the left upper calyces. So this is what we classically see when you see a central tumor. One of the differential diagnoses has to be TCC, transitional cell carcinoma, which is the most common type of urothelial cancer. Here, it can be anywhere along the urothelial lining. So here we see a filling defect in the urogram. Here we see a filling defect in the ureter itself, okay? Risk factors include smoking, phenacetin, dyes, and cyclophosphamide. Here we see sort of the bladder part of the cystogram, or urogram, right at the bottom, excuse me. And there's a mass here that's causing a filling defect. And then here is this is an MRI. So with MRI, we see the soft tissue much better. You can see the stalk here on this papillary TCC that we see on cystoscopy. So that's bladder cancer and upper tract TCC. We're going to move on to traumas. So trauma and mechanical disorders. Here is, we call this a cystogram, or it could be an extratorrhea phase of the urogram. You just wait a long time so that the bladder fills with contrast. And here, is this a normal looking bladder? What do you see in those? There's fluid, correct, yeah. And where is the fluid? Yeah, so there's the bladder here, and then, but you see that there's urine, right? There's contrast fluid outside the bladder. So this is extravasated contrast. And they call it the molar shape. So if this was a tooth, this is, I guess, part of the tooth extending down and into the space of Retzius, which is a space between the pubic symphysis and the bladder, suggesting extraperitoneal bladder rupture. And that's important to distinguish from intraperitoneal bladder rupture because this is treated conservatively. So here we see similar, right? We have contrast extravasating, and that's consistent with a rupture. Here we see this, what is this thing in the bladder? This non-enhancing dark thing. Any guesses? This filling defect that's floating in the bladder. Clot, yeah, this is a giant, patient's probably bleeding. And so there's a large clot in the bladder. Good. Here are other sequelae of trauma. Here we see what do we see here? Is this a normal looking kidney? No, there's a laceration, yeah. So this is a laceration, and there's a category. You don't need to know it, but just there's different category, and depending on the category, it'll dictate treatment options. So if it's category 1, which is what this is, you just watch it and just, hang tight. If it's an avulsion injury, for example, or you have vascular compromise, then they're going to be more aggressive about it and do like an angio revascularization, or in some cases nephrectomy. These trauma can lead to pseudoaneurysms where you have sort of blood squirting out of these segmental vessels, and patients are bleeding profusely, right? Because it's an arterial high pressure system. So the interventionists will go in and then plug up this vessel so that it stops the bleeding. Traumas. So we talked about ureteral. Oh, okay. So this is a normal finding of a normal CT urogram. So we do a non-contrast. If you look at the artery, there's no contrast there. The kidneys are also dark. And then this one, we see that the aorta is a little bit lit up, but you see the vein, the portal vein is lit up, and then the renal parenchyma is lit up. So this is a venous phase, the nephrogram, because you see the renal medulla lit up. And here's the extratorrhea phase, because now the contrast has made its way into the renal collecting system. It typically takes about 8 minutes in a patient with normal renal function. And here is another image of a beautiful CT urogram. And here, what is going on here? Is this a normal CT urogram? What is going on here? Compression of the ureter. Yeah, there could be some decompression. But what do you think about this? Is this in the shape of a ureter? Does it look like the bladder? It's leaking out, yeah. So there's contrast that's coming out and it's pulling here. So this is a ureteral laceration. And so that is, most likely from trauma. Okay, so ureteral laceration, it can be completely avulsed depending on the severity of the trauma or disrupted. Okay. Okay, we're moving on to mechanical disorders. Neurogenic bladder. So neurogenic bladder is when the bladder fills and the person doesn't feel it, and so it just gets bigger and bigger and distended. So it gets very lobulated, it's incredibly enlarged, and it's usually due to a neuropathy. So people with spinal cord injury from trauma, whatever, can develop neurogenic bladder. So it could be iatrogenic. It could be from malignancy or vascular insult. and then it leads to dysfunctional bladder. So the urine, diabetes. Diabetes, not typically not so, because you have to have a very severe neuropathy. So they'll probably get other neuropathic conditions before they get neurogenic bladder. But sure, we don't typically think of it associating with diabetes, but I mean, I guess in really severe cases, they could have it if they aren't already compromised from the cardiovascular standpoint. But the most common causes are multiple sclerosis, Parkinson's, Cauda-Equina syndrome, and paralytic syndromes, and stroke. So this is a cystogram. So so this is an MRI. The bladder urine is bright, so this is T2. This is a radiograph. So we put contrast in the bladder, and then now you can see it lit up, okay? So you see it's trabeculated, and that's abnormal looking. Traumas and mechanical disorders. So you need to know about posterior urethral valve, which was on the USMLE content list. This is typically a congenital condition, and it's the most common cause of obstructive uropathy in infants. Patients, so it's due to a valve-like membrane. It's a misnomer. It's not a valve. It's just a membrane. Like imagine if you had a layer of, let's say, you were like drinking boba or something, and then there was like a plastic sheath that was stuck, and you're trying to suck it, but you can't because there's a membrane. That's exactly what happens with posterior urethral valve. In the proximal urethra, there's a membrane. Here, there's a membrane. So when the urine fills, it can't. There's an obstruction because that membrane is blocking it. So once you diagnose the condition, this is a normal VCUG, right? The posterior urethra should be patent like this when the patient voids. But in this case, they're voiding, but there's a membrane that's causing an obstruction. So they go in and just ablate it with laser ablation to get rid of that membrane and reestablish the opening. In severe cases, they can get very severe reflux, which is what we see here. This is the ureter, and it's very tortuous. The calyces are blunted. They have severe hydroureteronephrosis, and it's bilateral because the obstruction is downstream. Here's an example of obstruction. So, hydronephrosis is an obstruction, but different causes of obstruction. So we saw, urethral valves in children, and here's an example of hydronephrosis on ultrasound that's due to a stone here. So the stone is in the right ureterovesical junction. So the ureter is dilated here, and the ureter should never be this large. The calyces are blunted. You have moderate to severe hydro from the stone. And it's a stone because you see this shadowing here. And because it's calcium, the acoustic waves cannot, it gets severely attenuated posteriorly. Other causes of obstruction in men, older men, BPH, benign prostatic hyperplasia. So the normal prostate is like a golf ball size. Here is probably a grapefruit size prostate. And here's a Foley catheter. Sometimes it's so bad they can't urinate and they have to catheterize themselves, or they have to have Foley catheter. These things can lead to overflow incontinence. Basically, you just have chronic obstruction so that the trooster, it doesn't contract as normal, and so you can get overfilling and you can have leak. You get urinary retention, which can lead to renal failure because you get severe hydronephrosis, and patients have to be decompressed, catheterized or relieved, either alpha blockers or TERP. This lead to post-renal azotemia because you have, severe bilateral hydronephrosis. And again, right, it could be from stones, BPH, cancer, congenital anomalies. Other mechanical disorders, here is a RUG, retrograde urethragram, and we see this outpouching here. This is a diverticulum or a tick. And here is an MRI. It's a woman. Here's the uterus. This is the side view. We call it sagittal. This is the pubic symphysis, the bladder. And we see this fluid-filled structure around the urethra. That's a urethral diverticulum. This, because they can lead to post-void dribbling. So, they'll urinate, but then after they finish, it'll keep dribbling because the outpouching is emptying. This, anytime you have stasis, it increases risk of infection, inflammation, and eventually cancers, right? Because you have chronic inflammation. Other mechanical disorders, so you can have strictures. So on the content list, USMLE content list, so strictures, this is an example of a stricture right here. You have hydronephrosis, and then in the region of the strictures, markedly narrowed. And that could be from other causes, right? It could be cancer, it could be from inflammation, it could be from radiation, a lot of different causes, infection. Here is a stricture of the urethra, which can be from, STIs, sexually transmitted infections, etc. Trauma, mechanical disorders. So here we're going to talk about urinary incontinence. It's 12 o'clock. I don't have that many more slides. Do you guys mind if I continue? I want to get through this because all of these things are on your content list and I want to cover these things. Is that okay? If you need to go, feel free to check out. It's all recorded, so you can watch it later if you have a meeting or something like that. But I want to get through this because these are topics that are covered under the content list. And I want to make sure I can answer any questions you might have if you have them. We're now on urinary incontinence. Urinary incontinence, we said could be from stress incontinence, overflow incontinence. So this is an MRI. The urine is bright, so we know it's a T2 exam. This is a dynamic. So the patient is on the MRI and they're rest, and then we ask them to Valsalva. So they increase their intra-abdominal pressure. And when this patient does that, the entire bladder prolapses. And you see, this is the bladder neck. It goes into the urethra. It's a woman. There's no penis. And so this is abnormal. So this patient has the abnormal angulation and prolapse of the bladder, which can lead to urinary incontinence. And also they're probably feeling a bulge. Here is another example, a dynamic pelvic MRI. So here's rest, and then when they Valsalva, we can assess the compartments, anterior, middle, and posterior compartments, and then assess the severity of their prolapse. So here we see an anterior compartment prolapse, and the urethra flips posteriorly, and so that's hypermobile. It shouldn't move that much, and it's moving because the muscles are weak. So stress urinary incontinence, it's an outlet incompetence. It can be due to urethral hypermobility. The muscles are weak, so it just moves a lot more than it should when the patient voids. Or it could be an intrinsic sphincter deficiency. When patients cough, anything that increases the intra-abdominal pressure, patients will, leak. Risk factors include obesity, vaginal delivery, prostate surgery. So men who have prostate cancer can have the prostate removed, which is right next to the sphincter. So if they accidentally injure the sphincter, then the patients can have stress incontinence. There's different ways of diagnosis. One test per the first aid is a bladder stress test. You just have them Valsalva or cough, and then you can watch them leak. Patients can, if it's mild, they can treat it with Kegel exercise. It's just pelvic floor muscle strength exercises. And if it's severe enough, then they can get surgery to address it based on what the MRI findings show. Congenital, okay, we're almost done. Congenital findings. This is an example of vesical ureteral reflux. Basically, the urine reflex is up back because the ureters typically go into the bladder through a tunnel, and it's weak or it's shortened. So they have poor the mechanism is sort of compromised, so they have free reflux back into the kidney system. And this is bad because patients can get pyelonephritis, and then it can lead to scarring of the kidneys and renal failure. So they can treat that by re-implanting. So they'll remove the ureter and then put it somewhere else and then tunnel it. So there's surgical correction, and there's sort of minimally invasive treatment option where they put deflux to try to narrow the opening. Reflux mechanical disorder here is an example of hydronephrosis, which we saw previously. In children now, contrast enhanced ultrasound is becoming really popular. The contrast in ultrasound is CO2, and this is really great because you just breathe out CO2, and it's great for children, because you don't have to worry about renal damage, and you can just keep administering as much as you want because the patients just breathe it out. It's part of our normal sort of system. So anyways, here we see the contrast. It's lighting up the kidney, and you see it going into the ureter and the bladder. And so normally you shouldn't see this continuation of the ureter and bladder, but we see that here because the patient has like reflux. So this is ultrasound's great because there's no radiation, right? And these usually happen in children, so you want to spare them radiation. And with here, cystogram or VCUG, we use radiation. So a lot of the pediatric radiologists are now using ultrasound to spare the radiation exposure. Other congenital disorders, you can have duplicated collecting system. So you have two ureters. It could be partial or it could be complete. In this case, here's an example of a complete duplication. So this is a lower pole, and then the upper pole here, you have an obstruction. So that's just a congenital anomaly. But if it becomes complicated, then patients will need surgery because you can get chronic pyelonephritis and sequelae. Here we see a stone that's obstructing the upper pole moiety. Here is another congenital anomaly. It's called congenital megaureter. Okay, we're almost done. Horseshoe kidney. Here we see the two kidneys are fused together. So what you need to know is that the SMA sits here, so it can't ascend. So it's stuck in the region of the SMA. Here is another congenital anomaly. I thought it was the IMA. Oh, yes. I think I made a mistake. Yeah, you're right. It's the IMA, JJ. The SMA is up here above the renal vessels. And here are the presumably the two renal arteries, and then here's the IMA. Thanks for that. Here we have renal hypoplasia, congenital again. So the right kidney is asymmetrically congenitally small. And then you have like the compensatory left kidney. There's a cyst here. This can also happen in patients who have insult, congenital insult. So if they had reflux in the past when they were a child, they can cause atrophy of the affected kidney. Here is another congenital anomaly. It's a single solitary kidney. They just have an congenitally absent right kidney. These are usually associated with Müllerian conditions like bicornuate uterus and septate uterus, things like that. Here we have dysplasia, so you have cystic dysplastic changes of the right kidney, and then you have normal left kidney. Okay, so we are at the end. So what exam is this? I'm still going to request responses before I will proceed. Good, urogram. Good. Okay, and what is this? Perfect, abscess. And then what is this? TB, good. And then what is this? Good. VHL, good. And then what is this? What part of the kidney is the arrow pointing to? Fornix, good. Oh, okay, well, the calyx is here, and then you have the tip, which is the fornices. Good. That's all. Any questions for me?